Story 1. The Behavioral Mirror. The moment that stayed with me was not violent. No alarms sounded. No one ran. It was close to 4 in the morning, and the unit had that thin, overlit stillness it always reached just before shift change. I was sitting across from a patient in interview room 2, reading back a line from his behavioral observation note when he lifted his hand to his mouth the same way I did when I was trying to think. Then he smiled before I did, not after. Before, and when he spoke he used my exact cadence to tell me I was documenting the wrong person. What unsettled me was not that he sounded like me. It was that for one suspended second, I could not remember whether I had learned that voice from him. I was in my 3rd year of psychiatry residency at a university teaching hospital in Philadelphia, and by that point I had become comfortable with the overnight psychiatric unit in the way people only become comfortable with places that are unglamorous and relentlessly repetitive. It was a locked adult service on the 7th floor, 32 beds, fluorescent light that flattened every face, waxed corridors that always smelled faintly of antiseptic and overbrewed coffee. The unit took transfers from the emergency department, direct admits from medicine when delirium had been ruled out, and the occasional patient stepped down from intensive observation after a medical stabilization. On paper, it was an academic setting. In practice, at night it became procedural and strangely intimate. My overnight rotation ran from early evening into the next morning. I handled urgent evaluations, wrote admission orders, called attendings for restraints or involuntary medication when necessary, and tried to finish progress notes before dawn rounds began. By autumn of 2025, I knew which medication room cabinet stuck in damp weather, which nurses trusted silence more than reassurance, and which call rooms had vents loud enough to make a person believe someone was whispering in the wall. The staff was good, tired but good. A competent charge nurse could keep a psychiatric floor steady through almost anything. That month, the charge nurse on most of my shifts was Laurel Pike, who had worked inpatient psychiatry for more than a decade and had the calmest, restrained voice I had ever heard. She could direct a violent patient into a chair with the same tone someone else might use to request a pen. There was also Miles Fenwick, one of the senior mental health technicians, broad-shouldered, patient, and almost absurdly observant. If Miles said a patient had changed, I listened. If he said a patient was manipulating, I took that seriously too. On nights when the census was heavy, we divided the work in a rhythm that felt almost mechanical. One person charted, one person watched the halls, one person handled admissions. I liked that rhythm. It reduced uncertainty. The patient who changed that started as a straightforward admission. He came from the emergency department a little after 11 p.m. on a cold October night after a family-initiated welfare check. 34-year-old male, no acute intoxication on laboratory workup, medically cleared, no overt aggression, no reported suicidal intent, no florid psychosis. The emergency physician noted bizarre social behavior and increasing withdrawal over several months. His sister reported that he had begun echoing people in ordinary conversation, not in the classic immediate, automatic manner associated with echolalia, but in a delayed, almost selective way. He repeated gestures, he adopted posture. He borrowed turns of phrase hours after hearing them, sometimes days. She said it was unnerving but not threatening. The emergency department's psychiatric screener recommended admission because the family no longer felt safe managing him at home, and because his insight appeared markedly impaired. His name was Elliot Voss. I reviewed the chart at the workstation, then met him in intake bay 3 before security walked him upstairs. He was neatly dressed in hospital scrubs, hands folded, shoulders relaxed. He looked like the least psychiatrically distressed patient in the emergency department that night. He made good eye contact without staring. Speech was normal in rate and volume. Thought process was linear. He denied hallucinations. He denied intent to harm himself or anyone else. Affect was a little constrained, but not bizarre. If I had seen him in an outpatient clinic with his sister's collateral report removed from the equation, I might have coded him as anxious, guarded, and perhaps mildly odd, nothing more. I began the evaluation the way I began all nighttime admissions, by anchoring to basics: orientation, sleep, appetite, concentration. Recent stressors, substance use, prior treatment, trauma history, family psychiatric history, current symptoms. He answered with quiet precision. Then halfway through the interview, I noticed he had begun matching my posture. That was not unusual in itself. People in conversation often do that. It can signal rapport. It can also happen by accident. I shifted back in the chair and uncrossed my legs. A few moments later, he did the same. I set my pen flat against the clipboard instead of clipping it at the top. He placed his hospital bracelet hand over the opposite wrist. When I cleared my throat before asking about work history, he waited 2 beats and did it too. I made a note in the margin of my intake form. Possible behavioral mirroring. When I asked whether people had commented on his tendency to imitate them, he gave me a look I still remember because it seemed genuinely puzzled. I usually notice people first, he said. Then they get more comfortable. That answer was not incoherent, but it was not normal either. I asked him what he meant. He looked at my badge, then at my face. You slow down when you think the answer matters, he said. Most people do. I asked again whether he knew he was copying others. He smiled, and the smile was not hostile. If anything, it was professional, the way a resident smiles at an attending after being asked a question already. Answered in the note. I don't think that's the right order, he said. I admitted him on an unspecified psychotic spectrum diagnosis with rule-outs. That included emerging psychosis, autism spectrum traits not previously assessed, obsessive-compulsive spectrum phenomena, and less likely malingering, though there was no obvious secondary gain. I placed him on standard observation, started no standing antipsychotic overnight because I did not feel I had enough evidence to justify it, and wrote for as-needed medication only. Laurel read my note at the station and raised an eyebrow. So he's polite, organized, and creepy, she said. That is not in the chart, I told her. It is now, she said, tapping her temple. By morning rounds, he had become a curiosity. Teaching hospitals have a way of converting the unusual into a case presentation almost immediately. The attending on service asked whether this was true echopraxia or a more complex affiliative mimicry. One of the interns mentioned mirrored posture in trauma survivors. A psychology fellow brought up identity diffusion. We discussed observational parameters, response latency, whether to introduce structured interview tasks to test imitation under controlled conditions. For a day or two, it remained interesting. That is an important distinction. Interesting things do not frighten clinicians. Unclassifiable things do. I continued to see him because I had admitted him and because overnight residents often informally followed the patients who had confused them. During one interview, I deliberately altered small features of my behavior to see whether he would track them. I touched the edge of the chair instead of the armrest. He did the same. I used the phrase "to be clear" 3 times. By the end of the interview, he had started answering with "to be clear" as well. I asked whether he was aware of repeating me. He said, "Are you?" in such a neutral tone that I almost laughed. At first, I treated the whole thing as an excellent behavioral puzzle. I wrote observation notes with more detail than usual. During rounds, I presented examples and timestamps. Laurel began keeping informal tally marks on the back of a medication administration printout whenever she noticed him adopting staff habits. Miles said the patient had picked up his tendency to rub 2 fingers against his thumb while listening. Another resident insisted Elliot had begun using her exact phrase for redirecting intrusive patients. No one seemed alarmed. We were a psychiatric team. We observed behavior for a living. The patient reflected behavior. That was, professionally speaking, almost flattering. The first shift in tone came about a week into his admission. I was in the team room dictating a note when Laurel walked in holding 2 styrofoam cups of coffee. She handed one to me and said, "You do that now." "Do what?" She demonstrated by pressing her tongue briefly against the inside of her cheek before taking a sip. It was a tiny movement, barely noticeable. "That before you drink coffee." I told her I had probably always done it. She said I had not. She said Elliot had started doing it on day 2. Miles mentioned it, and now I was doing it too. I shrugged it off, but the comment stayed with me longer than it should have. Tiny habits become invisible because they are tiny. Once someone names one, it acquires weight. Over the next several nights, the unit seemed to fill with those tiny recognitions. Miles said Laurel had started folding behavioral observation sheets into exact thirds the way Elliot did. Laurel pointed out that one of the interns had begun saying that tracks in Elliot's flat, careful tone. A technician swore 2 patients who shared no room and no treatment group had both begun holding their meal trays the same way Elliot held his. The stories accumulated with the triviality of workplace gossip, but the emotional tone behind them changed. People laughed less when they mentioned him. I tried to formalize what I was seeing. During my interviews, I asked standard questions first, then changed one neutral behavioral variable at a time. Pace of speech volume, distance from the table, body angle. I documented response intervals. Elliot continued matching selectively, not mechanically. He did not mirror everything. He mirrored whatever I became most aware of. If I fixated on my own folded hands, he folded his. If I worried he was copying my phrasing, he borrowed the exact phrase I had just mentally marked as mine. More than once, I had the disquieting impression that the copied behavior did not begin until after I noticed it in myself. That was the first point at which I began mistrusting my own order of perception. Psychiatry trains you to respect observation while remaining skeptical of narrative certainty. Patients confabulate, families revise, staff unintentionally suggest. Fatigue degrades precision. Overnight work makes every clinician a little less reliable than daylight work. I understood all of that, so I tried to protect against it. I reviewed nursing notes before my own interviews. I asked people to write examples down before discussing them aloud. I made a point of not telling Elliot what I had observed until after sessions ended. I was trying to preserve clean data. It did not help. On a Thursday night near the end of October, I presented Elliot during overnight handoff to the incoming attending. Halfway through my summary, the attending interrupted me. "You've been using his language," she said. I stopped. "What language?" "That phrase. A little constrained but not bizarre. He used it about another patient yesterday in group." I told her that phrase was common psychiatric shorthand. She agreed. Then she asked when I had started saying it. I could not answer. I knew I had used it in countless notes over the years. I also knew, with a kind of cold embarrassment, that I now heard it in Elliot's voice. There are moments in clinical work when you realize a case has ceased to be about the patient's symptoms and has begun to expose vulnerabilities in the observers. We had reached that point. During case conference, discussion shifted from diagnosis to unit culture. Was Elliot exceptionally suggestible in a way that made everyone else more self-conscious? Had staff become primed to notice mimicry and started over-attributing ordinary convergence? Were we participating in a mild form of mass psychogenic influence within a high-stress environment? The attending asked sensible questions. Was sleep debt worsening pattern recognition? Were we inadvertently rewarding the behavior by centering it? She recommended reducing discussion outside formal rounds and asked nursing to continue neutral observation. For 2 days, people complied. Conversation about Elliot stopped in hallways and around the charting station. We limited contact to treatment needs. We discontinued the unit's casual fascination with him. That was when the memory issue began. It started small. Laurel asked me why I had switched to carrying my folded census sheet in my left breast pocket. I told her I always had. She stared at me. "No," she said. "That's new." Later that shift, I saw Miles turn to answer a patient question and rub 2 fingers against his thumb. When I mentioned it, he frowned and said he did not do that. He seemed honestly annoyed, the way people do when told about a mannerism that feels invasive simply because it belongs to them more than to anyone else. Then I caught myself writing a behavioral note in a syntax I did not like. Patient remained calm, cooperative and observant. No overt agitation, no spontaneous complaint. Effect appropriate to context. There was nothing clinically wrong with that language. It was sterile but acceptable. The problem was that I had a distinct memory of disliking that exact cadence in other people's notes. I revised it. When I reread the sentence a minute later, I could not remember whether I had revised it toward my own style or away from Elliot's. By the first week of November, I had begun reviewing recorded interviews from the unit camera archive after my shifts. Those recordings were not high quality. The interview rooms had ceiling-mounted cameras primarily for safety, not behavioral microanalysis. Audio was thin. faces washed out under fluorescent glare, but the footage was enough to settle certain factual disputes, and I told myself that was what I was doing, settling disputes. The first clip I pulled was from Elliot's initial interview in Intake Bay 3. I wanted to confirm the sequence of the early mimicry. I expected to see him matching my posture after I changed it. Instead, I saw something that embarrassed me so completely I almost closed the file. Was mirroring him. Not consistently and not in some dramatic way. But in the recording, several of the gestures I remembered as mine appeared to begin with Elliot and then migrate to me. He touched his wrist first. I shifted into the same angle later. He leaned back with one ankle tucked under the chair. I followed. I said to be clear early in the conversation, but he had already adopted my slower cadence before that, and I could not tell whether I had slowed down because of him or because I had heard myself through him. The footage did not prove anything supernatural. It proved something much worse for a clinician. That my confidence in sequence had become unreliable. I reviewed more interviews. In some, Elliot clearly copied staff. In others, staff copied him. In several, it was impossible to say. There was no stable origin point. Behavior passed between people the way reflections pass between facing mirrors, each making the other seem like the source. I should have stepped back then. I should have asked another resident to take over direct interviews and limited myself to secondary review. Instead, I became more involved, because uncertainty in a controlled setting can feel like an accusation. I wanted a clean answer. I wanted to demonstrate that there was one. The most disturbing interview took place during a quiet stretch between 1 and 2 in the morning, after the unit had settled and before the earliest risers started pacing. Elliot sat across from me in interview room 2 with his hands folded on the table. He had been on the unit long enough that his behavior had become ordinary to the newer staff. And that shift, I noticed something in him that I had not registered before. He seemed less like a patient waiting to be assessed and more like someone patiently allowing an assessment to continue. I asked him whether he ever felt that other people's behaviors entered him without permission. He tilted his head. That sounds dramatic. Do you feel influenced by the people around you? We all are. In a way that feels involuntary? He looked past me toward the dark monitor on the wall. You still think there's an original version of things. I kept my tone even. I think people have baseline traits. That would be convenient. I asked him what he thought was happening on the unit. He studied me for long enough that I became uncomfortably aware of my own breathing. Then he lifted his hand toward his mouth. I watched the movement because I knew it. It was the same gesture Laurel had named weeks earlier, tongue to cheek, fingers brushing the lower lip before speaking. I felt my face tighten before I realized why. He had not copied that from me, or perhaps he had. I no longer knew. You keep interviewing from the assumption that I'm the patient, he said. You are the patient. In the bed assignment, yes. That matters. It matters to paperwork, he said, not to direction. He leaned forward and with a calm, almost apologetic expression. He said the next sentence in my own voice, not a theatrical imitation, not mockery. My actual cadence, my pauses, the slight flattening of emphasis I used when I was trying not to reveal concern. I'd like to verify the timeline before we continue. I did not answer immediately. My hand had gone cold on the pen. He smiled very slightly. There, he said in his own voice again. You hear it now. I ended the interview early and documented it as increased boundary testing behavior with possible identity disturbance themes. That note still exists somewhere in an archive, and I suspect anyone reading it without context would think I had done the professionally appropriate thing. Perhaps I had, but by then I was no longer writing notes to clarify events. I was writing them to preserve a version of myself who still believed events could be clarified. The next morning, I presented the case on rounds and found myself stumbling over details I knew. The attending asked how long Elliot had been admitted. I said 2 weeks, Laurel said 3. Miles said closer to a month. We checked the chart. Admission date confirmed. Laurel was right. That should have ended it. Instead, I had the sinking sensation of discovering not that my memory was faulty, but that my emotional certainty about time had detached from the calendar entirely. In supervision later that day, I described the unit-wide suggestibility, the recording ambiguity, the accumulating confusion over small habits and verbal style. My attending listened carefully and asked whether I was sleeping. I told her not enough, but adequately. She asked whether I felt depersonalized, detached or cognitively slowed. I said no, that was mostly true. I did not feel dissociated in the classic sense. I felt copied, or more precisely, I felt distributed, as though traits I would once have called my own had become communal property on the unit, available to whoever noticed them first. Before my final week on that rotation, Elliot was discharged. His sister agreed to intensive outpatient follow-up. He did not require involuntary commitment. He remained calm, coherent, and functionally appropriate enough that holding him further would have been difficult to justify. He thanked the nursing staff with perfect courtesy. He thanked me last. "You should stop watching the footage," he said. I told him that was not his decision. "No," he agreed. "But it becomes harder after discharge." I asked what became harder. He seemed to consider the question honestly. "Separating observation from adoption," he said. Then he walked out with transport, shoulders set in a posture I recognized too immediately to like. I expected the atmosphere on the unit to normalize after he left. It did not. If anything, his absence made the problem easier to notice. Laurel still used a phrase she insisted she had never said before his admission. Miles still rubbed his fingers while listening. One of the interns developed my habit of turning the pen clip inward against the palm while presenting. I saw a technician stand exactly the way Elliot had stood outside the medication room window, weight balanced lightly on one foot, as if preparing to step into someone else's body language. These were minor things, but they were no longer attached to him. They continued without a source. On my last overnight of that block, I stayed late after sign-out and reviewed the earliest footage one final time. Not just Elliot's interviews, staff interactions, hallway conversations, rounds. I was looking for a stable beginning, some small untouched version of myself that predated his arrival. What I found instead was humiliating in its simplicity. In the clip from the evening before his admission, I was already doing the wrist-touching movement. In a clip from a week before that, Laurel was using the phrase she later attributed to Elliot. In an old hallway recording, Miles rubbed 2 fingers against his thumb while listening to a patient months before Elliot arrived. Almost every behavior we had come to associate with him already existed on the unit, scattered among us, trivial and unnoticed. He had not introduced those mannerisms. He had concentrated them. He had made us see them. That realization should have reassured me. It should have reduced the phenomenon to pattern amplification, heightened suggestion, a socially contagious hyper-awareness in a stressful inpatient setting. Instead, it terrified me more deeply than any psychotic outburst could have, because it implied that Elliot's real effect had not been imitation at all. It had been authorship. He had not borrowed our traits. He had redistributed ownership until none of us could say with confidence what had ever been singular. Near 4 in the morning, while I sat in the dark team room with the monitor glow on my hands, opened the video from my first intake interview once more. Elliot looked at me from the screen with that same patient, courteous attention. I watched our earliest exchange frame by frame. When I asked the first question, he adjusted in his chair. I adjusted after him. Then, just before the clip's timestamp advanced to the next minute, he looked toward the camera, past me, as if aware of the future viewer. His lips moved once. The audio was too poor to hear it, but I knew what he had said, or believed I knew. It was the sentence he had repeated to me on the unit, and the one that still returns when I catch a gesture in myself and cannot name where it began. "I don't think that's the right order. I finished residency months ago. I still write my notes carefully. I still trust procedure more than instinct. But now, when I present a patient and hear my own phrasing echoed back from a student, a nurse, or an attending who has never met the others, I no longer assume language belongs to the person using it. Some patterns do not spread forward. They circulate until someone notices the loop, and after that, the calendar itself starts to feel less dependable. Story 2. The Tuesday patient. The first time I understood that the problem was not a repeated patient, but a repeated night. The center was under blizzard restrictions, and half the exterior cameras were blind with ice. The intake printer kept spitting out wristband labels with the wrong date, and I was standing in assessment room 1 with a patient whose legal name, age, and county of residence were all different from the week before. He watched me compare the paper in my hand to the face in front of me, then told me with the same weary kindness he had used every other time that the discrepancy was mine, not his outside. The wind pushed hard enough against the reinforced glass to make the whole vestibule hum. Inside, I looked at the whiteboard calendar and realized Tuesday had been erased and rewritten so many times that the marker ghosts beneath it no longer matched the month. I worked crisis assessments for a regional behavioral emergency center in Billings, Montana. It was not a full psychiatric hospital, though people outside the system often thought it was. We stabilized, screened, held for observation, coordinated transfers, and determined immediate level of care. The center took law enforcement drop-offs, walk-ins, medical clearances from surrounding emergency departments, and involuntary detention evaluations from a wide radius that included rural counties, where behavioral resources were thin even in good weather. During winter, especially in a bad one, we became a kind of holding chamber between need and distance. By early January of 2026, the storm pattern had already been disruptive for weeks. Arctic air pushed down from the north, roads iced over without warning, and every forecast carried some variation of high wind, drifting snow, and travel restrictions. The center's staffing became a rotating exercise in contingency planning. People doubled back for second shifts because relief workers could not get in from Laurel or Roundup. We kept cots in the conference room. Security stored extra blankets in the staff lounge. The administrative director sent a series of increasingly strained emails about weather, contingency protocol, transportation reimbursement, and maintaining a calm therapeutic environment during periods of regional instability, which was polished language for sleep in your scrubs if you have to. My role was licensed but not glamorous. I was a mental health crisis worker, which meant I performed psychiatric screening evaluations, suicide risk assessments, de-escalation, safety planning when discharge was appropriate, collateral collection, and coordination with the on-call psychiatric provider. I knew the forms well enough to finish most of them from memory if the system went down. Presenting problem, mental status exam, risk factors, protective factors, substance use, capacity, recommendation, everything designed to reduce a distressed human being to a clear next step. I liked the structure of crisis work. People assume it erodes you, and perhaps it does, but it also gives you something to lean on. When a patient is frightened, disorganized, intoxicated, or ashamed, the steady sequence of evaluation can be a form of mercy. Name, date of birth. Where are you right now? What brought you in tonight? Are you hearing anything others cannot hear? Have you had thoughts of harming yourself? It is procedural, yes, but procedure has dignity when used properly. The patient I came to call the Tuesday patient first arrived during one of the smaller storms in late January. It was a Tuesday night around 11:40 p.m. by the intake clock over the secure door. Law enforcement brought in a man on an emergency detention petition after staff at a motel off Interstate 90 reported that he had been standing outside in the cold without a coat, staring at the plow route lights as if waiting for something. The deputies were irritated more than concerned. According to their report, he was calm, cooperative, and vague about why he was there. His name on intake was Warren Bell, 52 years old. White male, recently divorced, no local family, no documented psychiatric history in our system. Mild dehydration, no alcohol on breath, no obvious neurologic deficit. He answered questions appropriately with the faint, distracted politeness of someone who had already accepted the inconvenience of being processed. Short gray hair, clean nails, no coat as reported. He sat with his hands on his knees and watched the room like a person taking in architecture. I introduced myself and began the assessment. He was fully oriented, no evidence of acute psychosis, no suicidal intent, no homicidal ideation, speech normal, thought process linear. Insight partial perhaps, but not absent. He said he had been waiting for the roads to quiet down. I asked why he had chosen the motel parking lot in sub-zero weather. He smiled, looked at my name badge, and said, "Because you were on tonight." That was not alarming in context. We see paranoid associations, grandiose familiarity, and socially odd remarks every day. I redirected. "Have we met before?" "Not like this," he said. I documented the comment as vague familiarity, non-delusional in structure. The rest of the evaluation remained irritatingly normal. If anything, He seemed less symptomatic than some of the anxious college students we discharged with outpatient referrals. I contacted the on-call provider, discussed the lack of involuntary criteria, and completed a safety plan with motel return and next-day outpatient follow-up. Before security escorted him to the vestibule, he paused and looked back. "It gets easier if you stop trusting the date board," he said. I thought he was trying to sound enigmatic. Some patients do that when they realize hospitalization is unlikely. I forgot about him by the next weekend. Then he returned the following Tuesday. Same hour, same weather class, though the storm that night was worse. This time he came by ambulance from a truck stop west of town after telling a cashier he had missed his appointment again. His intake name was not Warren Bell. It was Dana Creed, female sex marker on the transport paperwork, though the patient presenting before me was plainly male. Age listed as 28, tribal affiliation noted. Address in a county I knew existed, but the street number corresponded to a range that did not. The paramedic apologized and said dispatch had been a mess all night. The patient looked at me with immediate recognition. "You kept the tie," he said. I was wearing the same navy tie I often wore during weeknight shifts. That alone should not have landed the way it did. But he said it with the comfortable tone of someone resuming an interrupted conversation. I checked the electronic chart for crossover. No record linked Warren Bell and Dana Creed. No shared birth date. No matching identification number. No prior encounter visible. I started a new evaluation, prepared to tease apart identity confusion, intoxication, or possible fraud. He remained calm, coherent, and clinically ordinary, denied hallucinations, denied active self-harm thoughts, no mania, no delirium signs. When I asked why transport had listed him under a different identity, he said, "Because they picked up the version they had." "What does that mean?" "It means you ask the same questions every Tuesday," he said. "You just don't always ask them in the same order." I will admit that annoyed me. In crisis work, procedural familiarity is easy for frequent utilizers to mimic. Some know risk screen language better than new staff. I thought I was dealing with one of those patients whose presentation remained just coherent enough to destabilize the evaluator without ever crossing into obviously disorganized territory. I tried changing the sequence. Instead of starting with mood and sleep, I began with medical concerns. He answered before I finished the question. I switched to orientation. He answered that too, then added, "Billings, Yellowstone County, Tuesday. Weather advisory, but not your Tuesday." I documented tangential temporal statements. Though the rest of the mental status exam still failed to support acute psychosis strongly enough to justify detention. Again, he did not meet criteria. Again, he was discharged. The third Tuesday, the center went into full weather lockdown. The blizzard warnings had intensified all afternoon. By evening, the highways east and north were under closure advisories. Wind gusts were pushing drifts higher than parked trucks, and our night supervisor had already told half the team to expect to sleep in the building. Intake volume dropped, then spiked, then dropped again in the peculiar rhythm severe weather creates. By 10 p.m., the center felt sealed off from the city. Snow struck the vestibule doors in a steady granular hiss. The sodium lights beyond the fence turned the drifted lot into an empty amber blur. At 11:23 p.m., law enforcement brought in the patient again. Different deputy, different county, petition, different name. Ezra Malloy, 71 years old. Veteran mild confusion reported at a gas station outside Columbus. On sight, I knew it was him, not because his face was identical. That is the part people ask me first, and it is the least useful. The face was always close enough to itself to trigger recognition, but not so fixed that I could call it impossible. Cheeks fuller one week, nose slightly narrower another, hairline altered, voice deeper or drier depending on the night. What remained unchanged was the composure, the manner of attending to the room, the expression of patient understanding when he looked at me, as if he knew I had been given an unnecessarily difficult case and did not blame me for resenting it. "You're getting better," he said as soon as we sat down. At what? At noticing where it slips. I checked his vitals, reviewed the petition, and started the assessment. He answered smoothly, without agitation. No overt safety risk, no intoxication, no disorganization significant enough to justify a hold. The familiar frustration rose in me again, but this time another detail intruded. His stated date of birth, written clearly on the petition, made him 71. The age box in the electronic intake summary showed 68. The wristband label that had printed from admissions showed 44. I thought it was a data entry problem caused by the weather-related system lag and asked registration to correct it. The registration clerk called back and said there was no error on her end. According to her screen, the date of birth field was blank. I walked to the front desk and looked myself. She was right, blank field. Yet the printed wristband in my hand still showed a full date. I kept that wristband. I still have it sealed in an envelope because I do not trust my memory of it anymore. From there, the inconsistencies multiplied, but always in small administrative ways first. The date on the staffing board did not match the date in the electronic chart header. A risk assessment form auto-populated with Tuesday, while the system clock in the upper corner showed Wednesday. A colleague swore she had already worked 3 consecutive Tuesdays that month, when payroll later showed only 1. The night supervisor said we would hold huddle at midnight, then corrected herself and said it was already past 1 a.m. We laughed, because people in a lockdown shift lose track of time. That is normal. What stopped being normal was how those errors clustered around the patient. Every Tuesday night he arrived under a new identity. Every Tuesday night he recognized me. Every Tuesday night he remained clinically ineligible for involuntary admission. If this had been a ghost story, he would have become more monstrous. Instead, he became more procedurally legible. I completed Columbia suicide ratings, violence risk screens, psychosocial summaries, and disposition recommendations on him under 6 separate names over the course of 2 months. Every one of them documented some variation of calm. Oriented, cooperative, mildly unusual, no acute danger. I started copying the assessments for myself before finalizing them. That was not policy, and I knew it. But by then I needed a stable archive outside the shifting electronic record. I kept de-identified notes in a legal pad stored inside my locker, recording the date as I understood it. Intake name, weather conditions, chief complaint, exact phrasing. After the 5th Tuesday, I laid the entries side by side and saw the repetition clearly. Not repetition within the patient, repetition within me. My opening questions matched from week to week with unnerving precision. My observational phrases repeated even when I tried to vary them. His responses drifted around demographic facts but converged around one theme. He had seen me before, just not in the same arrangement. During one overnight lull, I pulled archived schedules to confirm my shifts. That should have been simple. It was not. The posted paper schedules in the supervisor's office showed one pattern. The payroll export showed another. The badge access log for the employee entrance showed that I had entered the building on a Tuesday. I distinctly remembered spending home sick with bronchitis. Worse, the access log also lacked my badge scan on a Tuesday. I remembered vividly because that was the night a patient had thrown a chair. In triage room 2, when I asked security to verify the entries, the guard on duty told me weather days often caused duplicate or delayed uploads. His tone made clear he thought I was overstimulated from too many lockdown shifts. Maybe I was. Sleep debt and storm confinement are not trivial. Billings in winter can shrink a person's mental horizon to the radius of headlights and plow reports. I started doubting myself more aggressively. I checked my phone calendar. Tuesday entries existed, but the notes beneath them varied in wording each time I reopened them. One said storm hold. Another said mandatory overnight. A third on the same date said first Tuesday patient. I had no memory of typing that line. The center's medical director recommended I take a weekend off. I agreed. That weekend felt wrong in a way I could not explain. I slept normally, cooked, cleaned my apartment, watched a basketball game with the sound low. Yet my sense of sequence would not settle. Saturday felt preoccupied by Tuesday. Sunday felt borrowed. On Monday evening, I found myself standing in my kitchen staring at the wall calendar, trying to determine whether I had already crossed out that month's second Tuesday, or whether there had somehow been 3 of them already. I laughed at myself then, harshly enough to hear how strained I sounded. The next night, the patient arrived as a teenage girl named Molly Dane. That is the point where people stop believing me, so I will be exact. The intake demographics listed female, age 17. transferred from an outlying emergency department for psychiatric clearance after wandering into traffic. The person brought through our secure vestibule did not look 17 or female, or even especially distressed. He looked like the same patient filtered through an inaccurate record. His face seemed younger until you focused on it, then older, then simply familiar in the wrong category. The trash nurse glanced from him to the paperwork and mouthed what he saw me and gave the smallest nod. "You almost had the right month last time," he said. "I brought in the on-call provider before completing the assessment because I wanted another licensed observer in the room from the start." Dr. Helena Rowe was practical, unromantic, and difficult to spook. She reviewed the transfer documentation, interviewed the patient herself, and then stepped into the hall with me wearing the expression physicians use when reality has become inconvenient. "What am I missing?" she asked. "That it's the same patient," I said. "It is not the same patient on paper." "I know, she studied me for a second too long. Are you sleeping?" Everyone kept asking that. No one asked the more useful question, which was whether the room itself remained stable while I was inside it. Dr. Rowe repeated parts of the exam. The patient answered with perfect clarity, denied acute risk, and asked her whether she still parked under the east light pole when weather turned. She had never met him before, but her face changed. Later she told me she had indeed parked under the east light pole during storms for years because drifts stayed shallower there. She could not explain how he knew. He was discharged again. I began staying after my shifts to review intake camera footage, badge logs, and weather reports. I built timelines on scrap paper in the conference room using snowstorm dates as anchors. If the patient always came on Tuesday, I reasoned, and if the storms were creating enough disruption to expose some pattern, then the weather might provide an external fixed point when calendars failed. That assumption held for a while. The National Weather Service archive gave me storm dates, wind advisories, closure times, all of it objective and clean. Then even that began to fray. A blizzard warning I remembered clearly as happening the night of one evaluation was archived for Wednesday in one report and Tuesday in another. Regional summary. A facility lockdown email in my inbox carried a timestamp that placed it 43 minutes after I had already referenced it in a note. The disturbing discovery was not that records were wrong. Records are wrong all the time. The disturbing discovery was that every record contradicted a different version of Tuesday. At some point I realized the patient had never said, "We have done this before," in the ordinary sense. What he actually said, in different phrasings, was that I kept meeting him from different approaches. That distinction mattered. I was not reliving the same night. I was intersecting with nights that resembled one another closely enough to be mistaken for repetition. The clearest evidence came from the carbon copy intake forms I had hidden in my locker. One March morning, after a storm severe enough to close several county roads, I spread the pages across the staff break table and noticed that my handwriting changed between forms. Not naturally, the way handwriting varies with fatigue, but structurally. On one form, my capital letters leaned left. On another, they were narrow and upright. On a third, I wrote the word cooperative with the looped lowercase letters I had stopped using in graduate school. Yet I remembered writing all of them. One note, completed under the name Ezra Malloy, contained an instruction in the margin that I had no memory of leaving. Ask him what happened in the South Hall at 1:12 a.m. When I read that line, I felt the room go cold in the irrational, body-level way that precedes understanding. I checked the surveillance log for the South Hall on that date. At 1:12 a.m., camera coverage had dropped for 26 seconds during a wind-related power fluctuation. The next available frame showed me standing outside Assessment Room 1, hand lifted as if about to knock, though I had no memory of leaving the interview. Opposite me in the hall was another man wearing my center-issued fleece, my badge real color, and my tie. His face was blurred by the bad frame interpolation, but the posture was mine. I brought that footage to Dr. Rowe. She watched it twice and said the distortion was likely compression artifact, combined with motion blur. She was trying to help. She was also afraid of becoming the next person whose certainty frayed under proximity to this case. On the last Tuesday I worked before transferring out of crisis nights, the storm was not severe. That almost made it worse. No dramatic wind, No lockdown, just low cloud, dirty snow at the edges of the parking lot, and the kind of flat cold that makes the city feel paused. The patient arrived as a county social referral under the name Elise Harper, 41 years old, acute stress reaction. He sat down in assessment room 1 and looked at the legal pad I had brought in with me. "You finally kept your own chart," he said. I did not bother denying recognition anymore. "What are you?" He considered that politely. "An intake," he said. "That is not what I mean. It's the only part you can process." I asked him whether these were separate times. He shook his head slightly. "Separate arrangements," he said. "Time is how you file them." "Why Tuesdays?" "Because your center believes in Tuesday," he said. "New week, corrected staffing, deferred discharges, revised plans. Everything tries to settle by then." That answer sounds meaningless now, but in the room it felt precise. Institutions do have favored days. Tuesday is when backlog becomes workflow. Tuesday is where contingency pretends to become order. I asked him why he kept returning to me. His expression softened enough to suggest pity. "I don't return to you," he said. "You keep becoming the one in the room." Then he asked me, in the exact sequence I used for every high-risk intake, whether I knew where I was, whether I felt safe, and whether I had noticed any breaks in time. His tone was calm, clinical, and practiced. My pen slipped in my hand because I had heard those questions from myself too often to mistake them. I looked toward the observation window. For a second, in the reflection on the darkened glass, I saw not one interview but two. Him seated where he was, me opposite, and overlaid faintly behind us. Another configuration in which I sat in the patient chair while someone wearing my fleece, my tie, and my posture completed the form. The reflection vanished almost immediately, but the understanding remained. The patient did not belong to one disrupted chronology. He appeared wherever the center's procedures aligned closely enough for one version of the room to press against another. And each time that happened, the person most committed to sequence, evaluation, and disposition became the bridge. Not because they were chosen, because they were already trained to make incompatible narratives fit a single form. I ended the interview somehow. The chart later showed I recommended discharge with community follow-up and no involuntary criteria. That sounds right, I assume it is. He stood when security arrived and paused by the door. "Stop calling it repetition," he said. "That's why you keep waiting for the next one." Then he left. I transferred to a daytime role that spring. Better hours, less weather exposure, less crisis volume. On paper, it was a sensible career move. I no longer work storm nights and I no longer keep carbon copies in my locker, but every Tuesday, a little before midnight, I still feel the same anticipatory pressure in the hour, as though the week is trying to close around a seam that never sealed correctly. If a patient glances at the date board before answering my name, I check the calendar twice, and if the marker ghosts under Tuesday look thicker than they should, I do not trust which version of the week I have made it into. By then, quiet usually follows. Quiet is what institutions call stability, when no one wants to ask what was taken out of the room to achieve it. Story 3. The Quiet Hours. The closest I came to panic happened in the supply room behind the art studio. With my hand on a plastic drawer full of charcoal sticks and my own treatment notes spread open on the counter beside me. The evening groups had ended an hour earlier. The facility was in quiet hours protocol, the hall lights dimmed to their amber nighttime setting, and the ventilation system was making that low, oceanic sound it always made in summer when the air ran too cold against the warm exterior walls. I had just read a progress note I wrote 3 months before and realized it described a patient's grief in flawless clinical language without containing a single recognizable trace of feeling. Then I heard soft paper movement behind me. When I turned, the patient was standing in the doorway holding a drawing I did not remember making. It was a portrait of me with no mouth, no brows, no visible expression at all. On the back in my handwriting I had written "kept for later use." I was an art therapist at a long-term private psychiatric rehabilitation facility outside Eugene, Oregon. The official brochures called it a restorative campus, which was not untrue, though the phrase softened realities families sometimes preferred softened. We served adults with chronic mood disorders, psychotic spectrum illnesses, trauma-related conditions, complicated functional decline, and those long, resistant combinations of diagnoses that never fit cleanly into a single treatment promise. Some residents stayed for weeks. Others stayed for months or longer. We were not acute care, not exactly. We were the place people came after the worst crisis had passed and ordinary life still remained impossible. The facility sat on landscaped acreage on the edge of a wooded rise south of town, far enough from the main roads that the evenings belonged mostly to insects, distant tires, and the irrigation system ticking on after sunset. The main treatment building housed medication rooms, offices, conference spaces, and 2 therapy wings. Residential cottages radiated outward from a central path lined with ornamental grasses that turned silver in the wind. My studio occupied the west side of the 2nd floor, above occupational therapy and across from a meditation room no one used as much as administration wanted them to. In daylight, it was a generous room with high windows, long work tables, and storage walls full of paper, acrylic, oil pastels, collage materials, clay tools, and bins of donated magazines. In the evening, after the main program tapered and the campus settled, it became one of the quietest places in the building. I worked the evening program shift through much of the summer of 2026. My job involved process groups, individual sessions, treatment team consultation, and documentation of expressive functioning in patients for whom verbal therapies alone were inadequate or exhausted. That sounds idealistic when phrased that way. In practice, it meant I facilitated structured creative work and tried to observe what patients could not or would not state directly. Affect range, frustration tolerance, symbolic content, initiation, flexibility, self-concept, defensive style, capacity for play, capacity for metaphor. Art therapy attracts romantic misunderstandings. It is not mainly about talent, it is about contact. What a person can approach, avoid, revise, destroy, repeat. The evening shift suited me. Daytime treatment meetings could feel crowded with language. By 7 p.m., many residents had less energy for performance. Their work grew simpler, sometimes truer. I ran small groups after dinner, often themed around memory, grounding, identity, or future orientation. We listened to the hum of the building and the dry scrape of charcoal. We talked if talking helped and did not if it did not. I documented everything afterward in the electronic record while the studio still held the smell of paper dust and tempera water. The patient at the center of this began as a clinical disappointment. His name was Nolan Vale, 39 years old, admitted for treatment-resistant depression with severe functional impairment, emotional blunting, and a history that included failed medication trials, multiple outpatient programs, and 1 prior inpatient stay. He had no violent history, no disruptive behavior, and no tendency toward dramatic disclosure. In case conference, his primary psychiatrist described him as remarkably flat, but behaviorally compliant. Nursing said he was polite, completed hygiene prompting without issue, and attended most required programming. His individual therapist noted minimal spontaneous elaboration. When asked how he felt, he often said, "I can describe reactions, not feelings." That formulation interested me. Patients with severe depression often report numbness. Trauma survivors do too. So do people after years of overmedication or prolonged stress. Emotional constriction is common. But when Nolan joined my evening art group, he presented with a version of flatness that was peculiarly complete. He did the assignments. That was the first thing. If I asked the group to create a place they associated with safety, Nolan made a picture. If I asked for color-based representations of current emotional states, he selected colors and applied them methodically. If I offered free media choice and open process time, he chose graphite or colored pencil and worked until the last minute. Yet his pieces were not expressive in any ordinary sense. They were technically adequate but bloodless, arranged with care and no urgency. Not minimalist in a striking way, not dissociated in a fragmented way, simply absent, a chair against a wall, a cup on a table, a horizon line, a window. Repeated studies of ordinary objects with no visible investment in the outcome. There was nothing diagnostically spectacular about that. Plenty of depressed patients produce emotionally muted work. My initial notes reflected exactly that. Low effective engagement, preserved task persistence, limited symbolic emergence, possible defensive overcontrol. He seemed to be using art as another neutral task to complete correctly, rather than a medium through which to reveal anything. What changed my attention was not his artwork itself. It was what happened around it. After about 2 weeks, one of the psychiatric technicians who supervised evening recreation stopped by my office and asked whether I had noticed the West Wing becoming a little flatter. He did not mean acoustically. He meant interpersonally. Residents who usually bickered mildly over television choices stopped arguing. Two women who regularly lingered after group to show me extra sketches stopped bringing them. A man with chronic anxiety who usually filled silence with apologies started sitting through sessions without speaking at all. None of that was automatically concerning. In long-term care, mood fluctuates, treatment phases shift, medications change. Summer heat affects motivation. But I started looking more closely. The next sign involved staff. At our Thursday treatment planning meeting, I noticed the room was unusually subdued. Our nurse practitioner gave a concise medication update. The social worker summarized family contact. The psychologist reviewed behavioral goals, and I presented group engagement trends. No one interrupted. No one elaborated. Normally, these meetings carried at least some friction, not hostile, but alive. Differences in framing, small jokes, the restless vitality of professionals who care enough to disagree. That day, the conversation moved like a document being read aloud after revision. Even when people spoke, there was a quality of emotional distance I could not name. Afterward, as we gathered our laptops, the occupational therapist, June Halbert, stood beside me and said, "Do you ever feel like you've already had your reaction to something and can't locate where you left it?" That was such a precise description of the sensation that I turned to look at her properly. June was a lively, opinionated person, hard to flatten. She gave the impression of perpetual forward motion even when standing still. That afternoon, she looked professionally intact and personally remote, as if someone had lowered the saturation on her without changing the lines. "Tired?" I asked. "Maybe," she said, "or borrowed." I smiled because I thought she was being poetic. She did not smile back. Over the following month, I began documenting emotional presentation more aggressively across my groups. Not because I believed anything supernatural was occurring, but because a pattern of reduced affective range seemed to be spreading without an obvious clinical driver. Medication changes did not account for it, neither did seasonality. Residents from different cottages and treatment teams showed similar drift. They remained behaviorally stable. Attendance stayed adequate. Compliance with routine improved, if anything. But the room tone changed. That phrase, room tone, matters in psychiatric rehabilitation. Treatment is not only what happens in charts or offices, it is the emotional weather of the setting. People borrow courage, fear, agitation, humor, and hope from one another constantly. A campus can become brighter or heavier without any single catastrophic event causing it. Good staff learned to sense that. By midsummer, the West Wing felt quieter than it should have. I tried to approach the problem through ordinary explanations. Was a new medication protocol oversedating residents? Pharmacy review suggested no. Were we overstructuring evenings and reducing spontaneous interaction? Perhaps somewhat, but not enough to explain the emotional narrowing. Had recent discharges removed several more expressive residents and left a naturally quieter mix behind? A little, though again the timing was incomplete. The more I looked, the more the pattern seemed to follow proximity to Nolan rather than diagnosis or schedule. I did not mean that other residents copied him. This was not mimicry, it was subtraction. Patients who spent time in group with him often seemed less animated afterward. Staff who facilitated with him reported difficulty accessing emotional language. One evening, a resident named Trina, who had spent weeks working through intense anger in collage form, stared at a torn magazine page in silence for 20 minutes and finally said, "I know this matters to me. I just can't reach the part that proves it." Her eyes looked frightened, not dramatic, not panicked. Frightened in the way people look when a familiar inner function fails. I reviewed Nolan's treatment course. Notes from his individual therapist described persistent inability to identify internal states beyond physical terms. Nursing reports described him as respectful, punctual, and difficult to engage in feeling-oriented conversation. His roommate requested a room change after saying Nolan was too still, which administration treated as an interpersonal fit issue. During my individual sessions with him, he remained thoughtful and almost academically cooperative. I asked him directly about emotional numbness. "It's not numbness," he said. "That implies something remains and can't be felt. What would you call it?" He looked toward the studio windows, where dusk had turned the trees into dark vertical shapes. "More like storage," I asked him to explain. "I can tell when something would be too much for other people," he said. "So it goes somewhere quieter." "Where?" He picked up a pencil, turned it once in his fingers and said, "Usually where you ask me to put it." If a patient in acute psychosis had said that, I would have interpreted it differently. Nolan said it without delusional conviction, more like a metaphor he assumed I might understand. I documented it as possible dissociative conceptualization of affect. By August, the treatment meetings had changed enough that administration noticed. The clinical director remarked that campus acuity seemed muted. Staff conflicts declined. Incident reports dropped. Evening wandering decreased. From a purely operational perspective, things looked better. Yet several of us had the same private concern. The improvement felt non-organic. Residents were not recovering into richer emotional range. They were settling into smooth compliance and thin engagement. Families commented that phone calls felt less like them. One mother told a therapist that her son sounded calmer, but also strangely absent, as if he were reading a neutral summary of himself. I started archiving examples from art sessions. This is where my profession shaped the investigation differently than a typical psychiatric inquiry. I was not combing admission files or camera footage. I was looking at paper, sequence, repetition, formal qualities. I laid out months of resident artwork after groups ended, comparing line pressure, color choice, symbolic complexity, spatial use, and thematic content. I was looking for changes in Nolan's work, but what emerged instead was a drift in everyone else's. Pieces from regular attendees became cleaner and emptier over time. Busy composition simplified, color palettes dulled, images lost narrative tension. Residents who once used art to externalize conflict began producing objects without story. Cups, windows, folded blankets, closed doors, tabletops, empty birds' nests, parked cars with no drivers, nothing overtly morbid, just emotionally evacuated. When I arranged the work chronologically, the shift was unmistakable. Nolan's own pieces did not improve or deteriorate. They remained modest and still, yet the studio itself began to feel organized around them, as if other people's work was converging toward his emotional pressure. I consulted June 1st because occupational therapists notice functional nuance with a rigor I respect. We met in the empty dining room after dinner, charting carts parked along one wall, sunset turning the west windows copper. I showed her photocopies of several art pieces with identifying information removed. She studied them quietly. "These look sedated," she said. "They are not." "I know," she said. "That's the problem." She told me she had noticed a similar trend in activity groups. Residents lost frustration faster, but not because they were regulating better. They simply disengaged from their own preferences sooner. Tasks that used to trigger meaningful emotion now landed flat. One man who always became visibly proud after finishing woodworking projects had started placing them aside without looking at them. A woman who cried during music therapy now reported that the songs still mattered intellectually, but no longer arrived. We took the concern to a treatment team review. The psychiatrist suggested an institutional contagion of demoralization, not uncommon in long-term settings where progress is slow and staff burnout spreads quietly. He was not wrong. Burnout can feel exactly like atmosphere thickening. But that explanation failed to account for the clustering around one patient and one wing. It also failed to explain the specific effect Nolan's art seemed to have in the room. At my request, we added structured effect ratings before and after evening groups for a small subset of residents who consented. I kept the tool simple. Self-reported access to emotion, intensity of feeling, and ease of naming emotional state. Not a perfect measure, but enough to track changes. Over 3 weeks, a pattern emerged. Residents who spent more time seated near Nolan or discussing his work reported lower post-group emotional accessibility than baseline, not lower distress, lower access. They left calmer and less reachable to themselves. I should say plainly that I remained skeptical. I did not think Nolan was psychically draining people. I thought some interpersonal process in the room was suppressing expression, perhaps through a subtle form of overregulation or enacted emotional accommodation. Maybe his flattened style invited others into a deadened relational space. Maybe the group unconsciously organized around protecting him from affect intensity. These were plausible clinical hypotheses, and I explored them in supervision. Then the personal effects began. I had been divorced for a little over a year by then, and though I was functioning well, certain subjects still carried charge. One of them was music. My former spouse had been a cellist, and there were pieces I avoided because they still opened emotions I was not always prepared to handle before work. One Friday after a long shift, I put on one of those recordings while driving home through warm evening air and realized I felt nothing. Not relief, not sorrow, not even irritation at the absence itself. The music registered as structure only, bow against string, phrase resolution, duration. I turned it off at a stoplight and sat there with my hand on the dashboard, waiting for the delayed ache. None came. That alone might have meant exhaustion. But over the next week, similar blanks appeared. A resident I cared deeply about shared a breakthrough disclosure in individual session, and I responded with appropriate empathy, while privately noticing I was constructing the empathy from professional memory rather than feeling. June told a story at lunch about her father's failing memory, and I understood intellectually that it was sad while remaining untouched by it. In group, when another resident cried, I found myself watching the tear track down his face with the detached visual interest I would normally bring to watercolor bleed. At first that frightened me. Then, more disturbingly, it made work easier. Documentation flowed, boundary maintenance sharpened. I said the right things and left nothing unfinished. The quiet hour structure at the facility suddenly seemed ideal. Less emotional noise, better task completion, more precision. The part of me still healthy enough to worry recognized the temptation immediately. Emotional numbing can masquerade as competence, especially in healthcare. A professional who feels less may appear more efficient. So I began reviewing my own notes. That was what led me to the supply room on the night I mentioned at the beginning. I had printed 3 months of my art therapy documentation on Nolan and several related residents. Spread side by side, the progression was undeniable. Early notes contained my usual language, observational but warm, attentive to the felt life behind the behavior. Later notes became cleaner, more exact, and almost inhumanly balanced. I described grief as sustained attachment valence. I described joy as brightened prosodic and relational activation. Technically accurate, perhaps, but bloodless. Reading those notes, I had the same reaction one might have reading a stranger's textbook commentary on one's own family. Then I found the drawing. It had been slipped into a stack of extra newsprint stored behind the charcoal drawer. Graphite on heavy paper. A portrait of me seated at the end of the studio table in profile, shoulders slightly hunched, one hand around a mug. The rendering was competent but not showy. The absence of expression was total. The mouth was missing entirely, not erased but never drawn. On the back, in my unmistakable handwriting, were the words kept for later use. I heard paper shift behind me and turned to find Nolan in the doorway. Quiet hours policy technically prohibited residents from entering the studio unsupervised after 10 p.m. He should not have been there. Yet he stood with his usual mildness, no intrusion in his posture, as though he had come because the session had not concluded correctly. "Did I make this?" I asked. "You helped," he said. "What does that mean?" "You were overfull that week." "With what?" He looked at the drawing, rather than at me. "Lost anger. Relief you felt guilty about. You asked for a container. I did not." "You don't remember asking in words," he said. The air from the vent felt suddenly cold on my forearms. "Are you saying people put feelings into the artwork?" "I'm saying they put them somewhere," he replied. "Artwork is just acceptable." I told him to return to his cottage immediately. He nodded, as if the instruction were reasonable, and turned to go. At the door he paused. "If you take them back all at once," he said, "the room gets loud." After he left, I locked the studio and sat alone with the portrait and my printed notes until well past midnight. I was not thinking clearly enough to frame a responsible intervention, but one idea took hold. If emotional content had somehow been displaced into the artwork, then the archive itself mattered, not symbolically, functionally. The next week, Under the excuse of reorganizing storage, I began a private review of Nolan-related materials, every piece he had made since admission, every group work product from regular attendees seated near him, every collaborative project from the West Wing over the previous 2 months. I stored them in flat files in the supply room and cataloged them by date, participants, and observed affect during creation. The more I handled them, the more uncanny the collection became. Not because the pieces were dramatic, quite the opposite, they looked harmless. Modest still lifes, muted landscapes, careful contour drawings, abstract blocks of gray and blue. Yet certain ones produced a bodily sensation I struggled to classify. Not emotion exactly, pressure latency, as if a reaction were waiting behind a membrane. I ran a quiet experiment with consent from 2 residents by having them revisit earlier works in individual session and describe their responses. Both chose pieces made during weeks of documented flattening. Both recognized them as their own. Neither could initially connect to why they had made them. Then, when I invited each to redraw the same image with full permission to alter anything, both became unexpectedly emotional. One started crying before the pencil touched paper. The other grew angry and could not explain why. The reaction did not come from the original piece alone. It came in relation to it, as if the older work had been preserving an unfinished state. I took that to Nolan in individual session. He listened with his hands folded, expression nearly unreadable. "Are you doing this on purpose?" I asked. "No," he said. "Purpose makes it sound aggressive." I don't keep things well inside," he said. "If a room lets me, I use surfaces. Other people's feelings are not yours to use." His face changed at that, not defensively but with genuine confusion. "I'm not taking them," he said. "I'm preventing overflow." I asked from whom. He gave a small shrug. "Usually whoever is closest to breaking the room." That answer disturbed me because it fit too much. Psychiatric settings are always near rupture. Someone is grieving, terrified, psychotic, ashamed, furious, dissociated, manic, hopeless. The emotional labor of keeping a facility bearable depends on endless distributed regulation. If one person had learned, by pathology or by some other means, to absorb and relocate the overload, the immediate environment might indeed become calmer, more manageable, more operationally successful, and profoundly less human. I should have reported everything in more direct terms then. Instead, I became complicit through curiosity. I justified it clinically. I told myself I needed stronger evidence before alarming the team with language that bordered on magical thinking. I expanded the affect ratings. I mapped seating charts. I reviewed treatment participation against art group attendance. I also kept the archive hidden and visited it during late quiet hours when the building was dim and the west windows reflected the room back into itself. I would pull a drawing from a folder and wait to see whether anything moved in me. Sometimes nothing did, sometimes abruptly. A rush of feeling came so concentrated and contextless that I had to sit down. Shame not tied to my own memory, tenderness without object, irritation sharp enough to feel borrowed. Once I held a graphite study of a lamp made by a resident with chronic trauma and became flooded with protective anger so intense I had to grip the table until it passed. The next morning, that resident arrived in session and spoke for the first time about a childhood bedroom she had not mentioned before. It became impossible to maintain the hypothesis that this was ordinary contagion. The climactic shift came during a late August treatment planning retreat, one of those half-day administrative exercises designed to realign goals before the fall census increase. Representatives from each discipline sat around a long conference table, with coffee, printed metrics, and overly cold air conditioning. Our clinical director praised improved behavioral stability, reduced evening incidents, and increased resident compliance. On paper, the facility looked healthier than it had in months. Then a family therapist named Grant Winter, usually careful and diplomatic, said in a flat voice, "I don't think our residents are getting better. I think they're becoming easier to manage." No one responded immediately, not because they disagreed, because the sentence entered a room already thinned of feeling and found no surface to strike. I looked around the table and saw it clearly then. June sat with her hands folded too neatly. Grant's face carried no conviction despite the truth of what he had said. The nurse practitioner stared at her own notes with mild, almost affectionate detachment. We had all begun valuing the calm because we could no longer feel what it cost. In that same moment, I noticed a stack of resident art reproductions on the side credenza for an upcoming donor newsletter. Nolan's small graphite drawing of a window had been placed on top because the marketing coordinator thought it was serene. The sight of it in that context, stripped of everything it had been doing in the building, sickened me more effectively than weeks of suspicion. We were aestheticizing absence. That evening I went back to the studio after groups, opened the flat files, and did the most irresponsible thing I did that summer. I gathered a subset of the archive, mostly pieces linked to residents whose emotional access had declined most sharply, and brought them into the main room. My intention was vague and half-formed. I told myself I wanted to test Nolan's warning. In truth, I think I wanted to force a correction, to restore something by breaking the container. I laid the pieces across the tables in silence while the building entered quiet hours. Outside, the sky held that Oregon summer afterlight that lingers pale blue long after sunset.